Okay, hi everyone. Thank you for joining us this evening. Today's tutorial is on the menstrual cycle and its disorders, and it's given by Dr. Baker. Just a few rules. If you're watching on the Zoom, if you have any questions that are relevant to what's being covered in the moment during the tutorial, just pop them into the chat. If you have any questions that can wait till the end, pop them into the Q&A. If you're on a Facebook live stream, just comment your questions and we will send them to Dr. Baker and she will address them when appropriate. That's all from me, and I'll hand over to Dr. Baker now. Thank you.
So hi, my name is Ellie. I'm currently in F2 and I'm doing a lecture today about the menstrual cycle and menstrual cycle disorders. So just a brief disclaimer from becoming a doctor. So this lecture isn't to replace your revision, isn't to replace any medical advice that you need to seek. So it's just for revision purposes only. So these are our learning objectives today. So the first one, to understand the menstrual cycle, how it works and the hormones involved in it. The second learning objective, to go through these main menstrual disorders, so amenorrhea, oligomenorrhea, dysmenorrhea, menorrhagia, and we'll be talking about the causes, investigations and management of those. So firstly, just to go through the menstrual cycle. So the menstrual cycle is actually, unfortunately, really quite complicated, and it is more complicated than this diagram. But these are the main sort of hormones that make up the menstrual cycle. So we'll go through these, but just keep in mind there are other hormones and things which play a role, for example, thyroid hormones, and that's why thyroid disease can affect women's periods. But this is kind of a simplified down version of what goes on. So it's the hypothalamus pituitary ovarian axis that's often talked about in the menstrual cycle, and it involves these hormones here. So obviously you can have a little read of what the hormones do, and as we go through the axis, we'll kind of discuss them. So it starts off with the hypothalamus, obviously in the brain. The hypothalamus releases GnRH, so that's gonadotrophin releasing hormone, and it releases that in a pulsatile fashion, and that hormone, GnRH, acts on the anterior pituitary gland in the brain. That stimulates the anterior pituitary to release FSH and LH. So these are two gonadotrophin hormones. So FSH stimulates the development of follicles in the ovaries, and LH stimulates ovulation and also stimulates the formation of the corpus luteum, which supports a pregnancy if fertilization and implantation occurs, and corpus luteum produces progesterone. So once the anterior pituitary has released FSH and LH, these two hormones then have an effect on the ovaries. So the ovaries produce estrogen. Estrogen has lots of functions. It's a systemic hormone, has lots of functions throughout the body. Its effect in the menstrual cycle, it helps regulation, and it also helps thickening of the endometrium to support a pregnancy. And then, like we said, the corpus luteum then produces progesterone, and progesterone is the main hormone which is involved in pregnancy, so it helps stimulate the endometrium to receive implantation of the fertilized ovum if fertilization occurs during that cycle. So as you can see, the hypothalamus releases GnRH, stimulates the anterior pituitary to release FSH and LH, which works on the ovaries to produce, this is estrogen, estradiol, and progesterone. Activin and inhibin are also sort of side hormones that are produced, and they essentially work in this negative feedback loop. And this feedback loop's actually a little bit more complicated as well, unfortunately. So estrogen and progesterone kind of in lower levels have a negative feedback on the anterior pituitary, but in higher levels they seem to have a positive feedback and actually stimulate the release of FSH and LH. So that seems a bit confusing, but in the next slide we'll kind of hopefully go through it a bit better. It'll make a little bit more sense. So this is the menstrual cycle physiology, and you might have seen especially this kind of graph at the top here. So this dotted line here with the E2, that's estrogen. This one with the big spike, that's LH. This one here with the lower spike, that's FSH, and the one that goes up at the end, that's progesterone. The second bit of this graph just shows what the ovary is doing during that time, so the formation of the follicle, ovulation, the corpus luteum, and the bottom bit is how the endometrium looks, so the menses with its shedding and then it getting thicker. So essentially, when you hear people talking about menstrual cycle physiology, they will usually talk about either 2 or 3 phases. We'll go through it in 3 phases because I think it just makes it a little bit easier. So in general, the menstrual cycle lasts about 28 days for most women, that's the average, but 25 to 36 is a sort of normal range. When we refer to day 1 of the menstrual cycle, that means the first day of menstruation, so the first day of the period, and usually ovulation occurs around day 14. So the 3 phases that people refer to is the follicular phase, that's at the beginning of the menstrual cycle, the ovulatory phase when ovulation occurs, and then the luteal phase. As we know, some women will have longer and more irregular cycles than this, and that irregularity usually comes from the follicular phase. So the luteal phase usually is 14 days in most women, and then the follicular phase can range from anywhere to sort of 13 to 14 to 30 days if the woman's menstrual cycle is very irregular. And then menstrual bleeding usually lasts around 5 days, but the average is 3 to 7. And blood loss overall is about 20 to 80 mils, and that's for people with normal menstruation, not with amenorrhoea. So if we just go through the phases, I've written, just so you all know, I've written really detailed notes on the note sections of these slides, and I think Becoming a Doctor are going to put the slides with the note sections up on their website afterwards. So you don't need to write all this down or try and listen and understand it, and then the notes will be there afterwards for you to go over again. So the follicular phase is day 1 to day 13 approximately, but like we said, it can become longer in women with irregular cycles. Day 1 refers to the first day. Sorry, someone's just asking, is it 20 to 40 mils? So 20 to 80 is the average blood loss in one menstrual cycle. More than 80 is an abnormal, what's considered an abnormal or menorrhagia. Okay, so day 1 is the first day of menstruation. During this time, estrogen levels, so this one here, and progesterone levels are relatively low. Those low levels of those 2 hormones cause breakdown of the endometrium here, and that allows the endometrium to shed. Because of the low levels of estrogen and progesterone, this allows a pulsatile release of GnRH from the hypothalamus. And this causes a slight increase in FSH. FSH then goes along to stimulate several follicles inside the ovary. And the first follicle to actually mature is called the Graafian follicle. And the Graafian follicle will be the one that then releases the egg. The Graafian follicle then begins to produce estrogen. So estrogen then inhibits the maturation of the other follicles, and the reason for this is we only want to release 1 egg per cycle. We don't want, this aims to prevent multiple pregnancy. Obviously it's not 100%, and sometimes more than 1 egg is released. Estrogen at this time also then goes to start thickening the endometrium here, and also thins the mucus in the cervix to allow sperm to enter into the uterus. So FSH then falls here slightly, and that's because of negative feedback on the estrogen, So negative feedback of estrogen onto the anterior pituitary, which means FSH falls slightly here. Eventually, like I said on the previous slide, there's some sort of converse mechanism where actually, as the estrogen levels begin to rise here, that actually has a positive feedback on LH, And that is what causes, or thought to cause, this big spike in LH, which occurs and stimulates ovulation. So that doesn't make that much sense, but it's basically estrogen in a low level has a negative feedback. Estrogen, when it reaches a higher level, actually has positive feedback and causes LH release. So around this middle time, it says ovulation here, this is referred to as the ovulatory phase. It's very short, only about 16 to 32 hours. So sometimes it's not sort of put into the graph, but that's what this phase here is in the middle. So this big spike in LH then causes ovulation. So the ovum is released from the follicle in the aim that it will then become fertilized. This big spike in LH also stimulates the development of the corpus luteum. So the corpus luteum is basically that follicle which has then just released the egg and starts to form what's called the corpus luteum. The corpus luteum produces progesterone, and the reason for that is to support the pregnancy if the egg is fertilized. You might see down here as well, there's also a spike in FSH around this time. So the reason for this isn't clear, and I don't think the mechanisms were understood, unfortunately. But it's thought that this spike is caused by this rising level in progesterone. So progesterone at high level has a positive feedback on FSH and causes this spike here. We don't really know what the spike in FSH does or why it's important yet. Straight away after the LH spike, you can see that the estrogen starts to decline. And again, we don't really know why that happens. It's another mechanism which isn't well understood. This rising level in progesterone here then has a negative feedback. So in that cycle, a negative feedback on the LH and the FSH, and they start to decline again. And that's when we enter the luteal phase. So someone's saying, what's a corpus luteum? So a corpus luteum essentially is a fancy name for that follicle that released the egg. After the egg's been released, it forms it forms a sac, another kind of cystic looking structure on the ovary called the corpus luteum. And the corpus luteum produces progesterone. Progesterone is there to make the endometrium thick to try and increase the chances of implantation of an egg if it's fertilized. And the corpus luteum continues up until a certain point in the pregnancy, and it helps to support the pregnancy to grow. Sorry, there's another question. Then we go into the luteal phase, which is the last phase of the menstrual cycle, and this is the phase that usually is 13 to 14 days and usually stays around that time, even in irregular cycles. So the LH and FSH during this time are low. The corpus luteum here will continue to produce progesterone, which thickens the endometrium to prepare for implantation. Progesterone also then thickens the cervical mucus, and that's the idea is that is to prevent any further sperm or any bacteria from getting into the uterus. So then if fertilization of the egg and implantation of the egg don't occur, then the corpus luteum starts to degenerate, and therefore the progesterone levels start to decrease. And that will sort of allow the cycle to start again. So allows the decrease in progesterone and estrogen, allow the endometrium to break down and shed, and that kind of starts the cycle again. These low levels of progesterone and estrogen then allow the anterior pituitary to start releasing FSH and LH again, and basically we start the whole cycle all over again. If fertilization and implantation do occur, then the pregnancy starts producing human chorionic gonadotrophin, which is what we know as beta-HCG. That's how we test if someone's pregnant. This HCG stimulates the corpus luteum to keep it going, and the corpus luteum then continues producing progesterone, and that supports the placenta and the pregnancy up until a point that the placenta and the pregnancy are big enough to make their own hormones, and then the corpus luteum breaks down. If the Graafian follicle produces estrogen in the follicular phase, what produces estrogen in the luteal phase? Okay, so like we said before, estrogen starts to decline immediately as this LH spike happens. Like I said, we don't really know why that happens. We think maybe, as you've said, because the follicle is not producing estrogen anymore. So that's why we get this decline here. This second spike, it's thought, although it's not known, but it's thought that the corpus luteum also produces some estrogen, but to a smaller extent. And that's why we get the second spike of estrogen in the luteal phase. But that's not 100%, but that's what the kind of research and science suggests at this time. So I hope that answers that question. So that was all a bit complicated, but hopefully it makes a bit of sense. And like I said, you should be able to see the slides afterwards, and then you can kind of go through my notes at the bottom and hopefully make some sense of it in your heads. So there's quite a few questions throughout this, because I know some feedback is that people like questions. So the way which this is done is via the poll function. So if I launch the poll now, hopefully you can all see it and we can answer this question. So the poll. So the question is, the spike in which hormone is responsible for ovulation? So if I launch that now, you should all be able to answer. Just give you a few more seconds. Okay, I think most people have answered. So yeah, most people have said LH, which is correct. So if we just go back to this slide here, this deep black line is LH, and this spike in LH here causes ovulation, which happens immediately after the LH spike. Okay, so if we move on to just talking about some menstrual disorders, the first one of, well, the reason why we kind of talk about these and learn about these for you guys. So these things actually do come up in OSCE stations quite a lot. I had some of these history taking stations, and so people presenting with mainly menorrhagia, but also secondary amenorrhea or oligomenorrhea, and it's basically taking a history from them and then answering the questions at the end, so giving a differential diagnosis. So hopefully after you've talked about these a little bit, you'll be able to go away and think about what kind of questions you would need to ask during your history and what kind of differential diagnosis you'd be able to give at the end of the station. And so the first one I'm going to talk about is amenorrhea. So this is a definition of amenorrhea. So amenorrhea is the absence or cessation of menstruation. So essentially there's two types. There's primary amenorrhea and secondary amenorrhea. So the exact definition of what these are isn't sort of agreed between experts, but in general, primary amenorrhea is the failure to establish menstruation by the age of 15 to 16 years old if the girl has other normal secondary sexual characteristics. So these are things like axillary hair, pubic hair, breast development. So if she's got these other characteristics, but she's still not started menstruation by 15 to 16, that's considered primary amenorrhea. Or if by the age of 13 to 14, she's not started menstruation and she has none of those other characteristics, so she has no breast development, no auxiliary pubic hair, things like that, then that as well is considered primary amenorrhea. And primary amenorrhea is actually quite rare. The prevalence is about 0.3%, so we don't see it that often. Secondary amenorrhea is slightly more common. So that's when menstruation ceases in women who have previously had menses. So again, it's a little bit difficult with the definition, depending on what the menstrual cycle was like before. So if the woman had regular menstrual cycle before and she was getting regular periods, it has to be 3 to 6 months with no periods before you would term it secondary amenorrhea. If she had oligomenorrhea previously, so she had very irregular periods or long cycles, then most people would say it has to be at least 6 to 12 months with no periods before you would term it secondary amenorrhea. But like I said, this isn't exactly agreed on, and it's not a set in stone thing, but that's the kind of timeframes that are suggested. Like I said, it's slightly more common, so it's about 3 to 4% prevalence in women of reproductive age, and it's actually much higher in women who exercise a lot, so competitive athletes, dancers, etc. It can be up to 60% in these women. So then moving on to the causes of primary amenorrhea. Unfortunately, there are many, but this is basically how we split it into, like we were saying before, whether they have secondary sexual characteristics or not. So if they do have secondary sexual characteristics, so breast development, hair, etc., but they're 15 or 16 and they still haven't had their period, then these are the main categories of causes. So physiological causes. So constitutional delay essentially means that there's no abnormality found, and actually they will just spontaneously get their period by 18 years of age. And it's quite often familial, so it's quite often useful to ask if it was a history, what age their mother, sisters, grandmother, etc. got their periods. Often this will be later as well. And if you've ruled out other causes, then it's possible it's just constitutional delay. Also, physiological causes pregnancy, so it is possible for these for people to get pregnant prior to their first period. Obviously, you ovulate prior to your first period, as we've just looked at, about 14 days before on average. So if the girl is sexually active, it is possible for her to be pregnant before she's even had a period, so that's something to always check as well. The second one is genitourinary malformations. These are these are congenital malformations that occur, and actually it might not be that the girl isn't having periods. It might just be that she cannot see her periods because of things like this picture on the right. So things like an imperforate hymen. So this is obviously a picture of the vagina, and the hymen is completely closed, and that means that she is having periods, but they're just not coming out of the vagina, so she's not able to see them. These are other these are other GU malformations of the hymen that can be seen. So you might have an annular, very small, a septate hymen. These girls would probably have some kind of period, but depending on how big that hole was, or they may not have period. So it's just looking, if it's appropriate, then doing physical examination to see whether this is the case. In some girls that may not be appropriate, but it could be a GU malformation that's caused that. Again, transverse septum, so that's this picture at the bottom. So that's another sort of congenital malformation. This is the main one that would mean that there's no periods. So a transverse septum, which means there's basically tissue all the way across the vagina, and therefore blood can't escape, and you can see the blood's all built up here. You can get a longitudinal septum as well, which means like this, you have a pocket of blood that's trapped, and that can cause things like pain, but usually they would still get periods because the rest of that would be able to come through. In a transverse septum, there might be no periods because the blood is completely blocked off from exiting the vagina. You can also have GU malformations such as congenital things. Some women are born without uteruses or without vaginas, and those are obviously malformations that can be seen, and therefore they will not have periods. The next one's endocrine disorders. So these are things that are for all women, really, not just primary amenorrhea, and we'll talk about them as well later. But things like hypo and hyperthyroidism can affect the menstrual cycle, hyperprolactinemia, so high levels of prolactin, that can cause no periods, and other systemic things like Cushing syndrome can also cause amenorrhea, or polycystic ovarian syndrome. So usually PCOS doesn't cause primary amenorrhea because it happens slightly later on and they get secondary amenorrhea, but it is a rare cause of primary amenorrhea. It can happen that a young girl has PCOS and never gets her period. So those are the main kind of causes when secondary sexual characteristics are present. And then we've got the second group, which is where those secondary sexual characteristics are absent. So again, there's quite a few of these, and the notes are a bit more detailed, but just to go through them briefly, you've got primary ovarian insufficiency. So these are usually due to things like chromosomal irregularities, for example, Turner syndrome, which you've probably all heard of. So Turner syndrome is 46XO, and they usually have streak ovaries and therefore may not have periods. Other chromosomal abnormalities are things like gonadoagenesis, so 46XX or 46XY. They may not have formation of their gonads, and therefore they may not experience periods. Although rare, girls who have had, or children who have had cancer earlier in life and had things like systemic chemotherapy may then have primary ovarian insufficiency and may never get their periods. But obviously that information would come from the past liquidacy. The second one is hypothalamic dysfunction, and that's kind of what we talked about earlier with the athletes. So due to that feedback loop and how complicated it is and all the hormones that we didn't talk about, high levels of stress, excessive exercise or excessive weight loss can basically cause a functional hypothalamic amenorrhea. So it causes impact onto the hypothalamus, and the hypothalamus doesn't release those hormones, and this means that the girl won't have her periods. Chronic systemic illness can also have an impact on the hypothalamus and cause the same thing. And anything else which affects the hypothalamic pituitary axis, so a pituitary tumour, previous radiotherapy to the brain, a previous severe head injury, anything like that can cause problems with the pituitary gland and therefore lead to primary amenorrhea. And then the last one is causes of ambiguous genitalia. Unfortunately, all of these things are actually quite complicated, and the way that they affect the embryo and embryology is quite complex, but things like 5-alpha reductase deficiency or congenital adrenal hyperplasia come into this category of ambiguous genitalia, and therefore they also may never get their periods. So that's the kind of last. These are quite complicated, but these are the kind of last and very rare causes of primary amenorrhea, with secondary sexual characteristics being absent. So then we just move on to what you do if someone comes to you with primary amenorrhea and the sort of investigations and how you come to a differential diagnosis. So obviously most important is history and examination. So you need to ask things like sexual history. Is it likely that she's pregnant? A family history. Was there constitutional delay in the family? Is that the likely cause? If you've got GU malformation and therefore you're still having periods but the blood isn't coming from the vagina, these patients often present with cyclical abdominal pain. So essentially the vagina and the uterus fill up with blood, which isn't able to escape, and that actually is called hematocolpus, and it actually can be quite painful. So kind of like an endometriosis type picture, they present with this cyclical lower abdominal pain and no periods. Obviously endocrine disorders, that's something to ask about in your systems review, to ask about things like thyroid symptoms, galactorrhea, so that's milk or lactation, and that happens in hyperprolactinemia, so high levels of prolactin. So these are things to ask about. With regards to the sort of primary ovarian insufficiencies, you can ask a family history of genetic anomalies. Sometimes these things can run in families, but it's more something you're going to pick up on an exam. And then with the hypothalamic dysfunction, it's more psychological, so assessing them for high levels of stress, if they've been exercising too much, do they have a low BMI, do they look like they're potentially suffering with an eating disorder. Those things can feed into primary amenorrhea. And then in your examination, it's a systemic exam looking for things like features of thyroid disease, features of Cushing's, features of PCOS, so things like hair, hirsutism, acne, maybe a high BMI. Features of Turner syndrome, things like being short-statured, often referred to as having a webbed neck, and scoliosis. So those things you might pick up on a general examination. And then, if appropriate, a pelvic examination. So depending on the age of the girl, your experience, and whether she consents and whether she wants a pelvic examination or not. Things like imperforate hymen, obviously absence of vagina, transverse septum can be picked up on pelvic examination, so that might be appropriate for you to do in your primary examination. And then to go through the primary investigation, so any girl who presents with any menstrual problems or any abdominal pain of reproductive age should always have a pregnancy test. Something you should always do on everybody, even if they tell you there's no way they could be pregnant. Some of them still are, so it's definitely something to do. A pelvic ultrasound scan, so this will give you a better assessment of pelvic anatomy. Whether this is done via the abdomen or transvaginally will depend on whether the girl is a virgin or not. But this can tell you obviously the presence of a uterus, the presence of a vagina. It can show you any outflow obstruction, can show you if the uterus or vagina is full of blood, which would suggest a DU malformation. And then blood tests are your primary things you want to do. So there's quite a few of these, but prolactin is something you might want to do if there's symptoms of hyperprolactinemia. A normal prolactin is less than 500. Prolactin more than 1,000 is considered to be very abnormal. So these patients are usually referred to endocrine, and the most likely cause is a prolactinoma, which is sort of a pituitary tumour. So they're likely to get an MRI of their head. If it's between 500 and 1,000, then this is usually repeated before anything is done with this. If it's persistently raised again, then referral to endocrinology. Other blood tests, PSH, so that's looking at thyroid function, obviously, if there's any abnormality in thyroid function. FSH and LH. So if these are high and the patient has any features of Turner's, then it's likely to be Turner's. If there's no features of Turner's, then it's a possibility for another chromosomal abnormality, and these patients are usually referred and they get karyotyping to see if they have any congenital chromosomal abnormalities causing their primary amenorrhea. If you have a low FSH and LH, that usually represents either constitutional delay or hypothalamic dysfunction, so this weight loss or excessive exercise type picture. A high testosterone, so if the testosterone is very high, it suggests one of those things we talked about, which are quite complex, like congenital adrenal hyperplasia. If it's only mildly raised, then it suggests more of a PCOS picture, and you'd have to put that together with your clinical signs and symptoms of PCOS and potentially a pelvic ultrasound to assess the ovaries to see whether they are polycystic. Most of these people realistically are going to be referred, and they will have lots more investigations in secondary care, but that will depend on what the diagnosis is. So the management, it's really difficult to talk about the management because there's so many varied causes that go into that, and the management really does depend on the cause. You won't be expected to know all of the specific managements of all of these things because it's quite specialist, but essentially you're going to think about referring to gynaecology if you think there's a GU malformation, and they will potentially then have surgery to then correct the GU malformation if possible, to allow them to then have periods. You're going to think about referring to endocrine if you suspect thyroid disease, hyperprolactinemia, any androgen excess, then that's for an endocrinologist to play with the drugs for hormones. And then if you think it's a hypothalamic dysfunction, so the excessive weight loss or exercise, then potentially referral to psychiatry, to dietitian, to CBT if they're having more psychological problems that's leading into it. And with these people, it's important to consider osteoporosis risk and prophylaxis. So this isn't something you would obviously think about straight away, but for people who have low levels of estrogen, so hypothalamic amenorrhea or high levels of prolactin or primary ovarian insufficiency, if it's things that's likely to go on and they're going to have a low level of estrogen for a longer time, they're going to be at higher risk of osteoporosis throughout their life. So you should assess them for their risk of fragility fractures, correct anything you can, so calcium, vitamin D, and then if it's something like primary ovarian insufficiency, then consider combined oral contraceptive pills, so artificially giving them the estrogen and progesterone, or HRT as well, similar thing, to artificially give them those those hormones. Sorry, so someone's mentioned, is PCOS managed by endo or gynae? So PCOS is considered to be a gynecological condition, and it's usually actually managed by the GP, unless all the things the GP has done hasn't worked, in which case it's usually referred to gynae. But gynae and endocrine do work together with these patients, because there's if there's symptoms that aren't being controlled, but overall it is managed by a gynecology team. And we'll talk a little bit more about PCOS a little bit more in depth shortly. So just to go on to talk about secondary amenorrhea, so like we said, that's women who have previously had periods and now their periods have stopped. And again, they're kind of split into two groups. So that's people with no features of androgen excess, or people with features of androgen excess. So again, like we said before, physiological, are they pregnant? Are they breastfeeding? Is that the reason why their periods haven't come back? Or are they 55 and actually they're reaching their menopause? So it's always important to think of simple things common. Then you've got premature ovarian insufficiency. So this is essentially women who are going through menopausal symptoms, the ovaries are starting to fail, usually considered to be less than 40 or around 40 years age. That's considered premature. This can be due to many things. Sometimes it's you can't find a reason. Sometimes it's previous chemotherapy or radiotherapy to the area that's caused the ovaries to fail. Some autoimmune diseases can also cause the ovaries to fail early. So that's something to consider depending on their age. Again, the same as with primary amenorrhea, hypothalamic dysfunction, so stress, exercise, weight loss, chronic illness, any injury to their head, any pituitary tumour, any previous radiotherapy to their brain, anything like that. Those are sort of hypothalamic and pituitary dysfunctions that obviously affects the axis. Other things to think about with the pituitary, things like Sheehan syndrome. So I don't know if anyone's heard of Sheehan syndrome, but that's usually occurs in women who have a pituitary infarction after pregnancy and after having a big PPH. So pituitary grows during pregnancy, and then if they have a big PPH postpartum, it can cause infarction of their pituitary gland. The pituitary stops working and they slowly present with these symptoms of their periods not coming back, they can't breastfeed, and general hypopituitarism. So that's another cause, quite rare again, but it is a cause. So you've got your kind of hypothalamic, then pituitary cause, and then you've got your uterine causes. So this can be things like Asherman syndrome. So Asherman syndrome is this picture here on the right. It's essentially scar tissue inside the uterus. Depending on where the scar tissue forms, it can prevent the blood from coming out through the vagina, similar to those GU malformations, which are congenital. This is obviously not congenital and has happened later on in life, but does the same thing and essentially stops the period from coming out. That can be due to things like surgery inside the uterus, so any termination of pregnancy, also severe pelvic inflammatory disease that can cause these kind of adhesions within the uterus. Other things are cervical stenosis, so similar thing, if you've had cervical surgery, for example, LETS for an abnormal smear, the cervix can become stenosed and not allow the blood to leave via the vagina, and that can be cause of secondary amenorrhea. And then you've got your endocrine disorders such as thyroid, hypo or hypothyroidism, and then iatrogenic. This is actually one of the most common causes, so essentially contraceptive drugs. A lot of contraceptive drugs cause amenorrhea. It's something that you should talk to women about when you're counselling them for contraception. It's not known to be harmful, but some women find it distressing and they don't like it. And obviously that would just be stopping the contraceptive. Other drugs like antipsychotics can actually cause this, and obviously surgery. So if they've had a hysterectomy or surgery on their ovaries or something like that, that can cause secondary amenorrhea. And then lastly, you've got this group of women here with features of androgen excess, so features of androgen excess, acne, hirsutism, your typical PCOS type things. So you've got PCOS, and then you've got things like Cushing syndrome. So these women might get this later on in life and then experience secondary amenorrhea. Just to go through the investigations a little bit. So again, you've got your history and examination, really, really important. Same kind of things. You want to know their age. Do they have menopausal symptoms? Are they simply going through the menopause? Are they pregnant? If you're thinking premature ovarian insufficiency, again, they would have similar symptoms of the menopause, and this is in women about 40 years of age, and they might have a family history of this. Your same things for your hypothalamic dysfunction, the weight loss, exercise, all the kind of things we talked about before, past medical history of any problems with the pituitary gland, uterine causes, you want to know their past medical and surgical history, simple kind of things in your history there. And the examination is essentially the same. You're doing a systemic examination for things like thyroid disease, Cushing's disease, and you can also do a pelvic examination as well in these women. And then you go on to your primary investigations, very similar things, pregnancy tests, always do a pregnancy test. Bloods, so FSH and LH, if they're high on 2 occasions, so this is usually done by the GP, if the GP measures them and they're high on 2 occasions and the woman's more than 40 years old, this suggests that the woman's just going through the menopause. If she's less than 40 years old, this suggests premature ovarian insufficiency, so premature menopause essentially. If FSH and LH are normal or low, this suggests there might be more of a hypothalamic cause. Looking at prolactin, like we said before, more than 1,000 is severely abnormal, and they're going to be referred to endocrine for an MRI head to look if they've got a prolactinoma or something like that. Testosterone, again, moderately raised testosterone with normal FSH, normal to high LH, and normal to high prolactin, and normal to slightly high testosterone suggests PCOS. If it's very, very high, it can be those other things we talked about before, like congenital adrenal hyperplasia. You also want to do your normal TFTs and things like that. A pelvic ultrasound can be useful, looking at the anatomy and also looking at the ovaries for things like PCOS. So on the previous slide, this would suggest a polycystic ovary. So polycystic ovaries on ultrasound is either 12 follicles or more in one or both ovaries, or an ovarian volume which is more than 10 centimetres cubed. But this has to go along with other signs and symptoms of PCOS. So just having polycystic ovaries on an ultrasound doesn't mean you have PCOS. A lot of women have polycystic ovaries, but they don't have the other symptoms that come along with it. And a pelvic examination or something like colposcopy, if you think the woman's got cervical stenosis, or if you think she's got another more anatomical cause for her secondary amenorrhoea. And then just going on to the management. So again, quite complicated and depends on the cause, but things that can be managed in primary care, menopause. Most women just need reassurance, but some women might want HRT and might request HRT to help them with their menopausal symptoms. Pregnancy can obviously be managed in primary care. Hypothyroidism can be managed with levothyroxine in primary care. Polycystic ovaries can be managed mostly in primary care. So the most common things you do is lifestyle advice, advising everybody to lose weight. Weight loss can help all people with polycystic ovaries. And it's managing their cardiovascular risk factors, so they're higher risk for things like diabetes. So it's managing those things. If they've got no periods, then we suggest cyclical progesterone, and that induces a withdrawal bleed. And then they would have a TVUS. And essentially the problem with PCOS is because you have no periods or very irregular periods, the endometrium can become thick, and that can actually put them at higher risk of endometrial cancer later on in life. So you basically need to offer them something to keep the endometrium thin, so some form of contraception, the coil or combined contraceptive pill or something like that. Then you can just manage their symptoms. So if they've got acne, then you would manage their acne. If they've got hirsutism, you would manage symptoms about hair removal, etc. Hypothalamic dysfunction can also be managed by the GP. So that's the same as we talked about before: psychiatry, therapy, dietitian, etc. And then your referrals are going to be either again to gynae or to endocrinology. So premature ovarian insufficiency might go to gynae, may need to help them with management of fertility. Previous uterine or cervical surgery, previous severe PID because they might have Asherman syndrome, or PCOS if you've been unable to manage their symptoms successfully in GP. And then endocrine, you've got things like high prolactin, or again, very high testosterone. They would be sent to endocrinology. And then for these women, it's the same: osteoporosis, prophylaxis, and also just contraceptive advice, because it is possible for these women to become pregnant. They have sometimes have some intermittent ovarian function and actually become pregnant. Someone's asking about testosterone and PCOS. PCOS is actually really quite complicated, and I think I don't really have time to go through it. I've already spoke for 45 minutes, I'm really sorry. But hopefully we can either go through it in a further tutorial, or someone can go through it with you and talk about the testosterone and all the hormones in PCOS. Sorry, I think it's a little bit too much for me to go through now. And then, are the blood tests done on a certain day in the cycle? For these women, they don't really have a cycle, so they've got a secondary amenorrhea and they're not having periods, and you actually don't know what the cycle is at all. But other things like fertility, we do blood tests on certain days in the cycle, but for these women, usually not, because you don't know what day they are in their cycle, because they're not having periods at all. So we've got another poll now, so just a quick question to go through of what we've just talked about now. So this question is with regards to secondary amenorrhea. If they have a high FSH and LH, a normal prolactin and testosterone, what does this suggest? Okay, I think most people have voted. So yeah, most people said premature ovarian insufficiency / menopause, and that is the correct answer. So I didn't give you the age in this question, so you can't differentiate between the two, but high FSH and LH with normal prolactin and normal testosterone suggests premature ovarian insufficiency or the menopause. And you can go back on the slides and have a look at that table, and that should make a bit more sense. So just quickly to go through oligomenorrhea, I'm not going to spend much time on it because it's very, very similar to amenorrhea, but oligomenorrhea is essentially periods that occur less frequently than every 35 days. Physiologically, this is very common in young girls near the menarche, or older ladies near the menopause. There's irregular ovulation and therefore they get irregular periods. Women who are breastfeeding might get irregular periods. Again, women on contraception, lots of contraceptions cause oligomenorrhea. Not really harmful, but again should be discussed with the women when you're counselling her about contraception. Hypothalamic dysfunction, so this weight loss, exercise, stress can cause oligomenorrhea, and then these endocrine abnormalities that we've already kind of gone through again can cause oligomenorrhea as well as amenorrhea. So then to move on to dysmenorrhea. So dysmenorrhea is painful cramping, usually occurring in the lower abdomen, either shortly before and or during menstruation. Again, divided into primary and secondary. So primary occurs in the absence of pathology. So many women experience this, there's actually nothing wrong, and they just get some pain around their periods. It's thought that this is caused by prostaglandins that the uterus produces in response to progesterone. So when the progesterone levels drop just before the period, prostaglandins are produced by the uterus, and this stimulates contraction of the uterus and can cause pain. Other women may say they have nausea, vomiting, diarrhea, etc. All of those are also thought to be caused by prostaglandins. Primary dysmenorrhea is usually something that occurs almost 6 to 12 months after menarche. So when periods start becoming regular, women will start complaining about dysmenorrhea. Usually starts just before menstruation and lasts for about 72 hours. And as the period goes on, the pain gets better. Obviously, because there's no pathology, their pelvic examination is normal. Secondary dysmenorrhea is basically something that caused by an underlying pathology. Often these women will have had painless periods previously and now they're complaining of dysmenorrhea. They might complain of pain that lasts after the period is finished, throughout the entire cycle, but worse when the period's there. And they might have other gynecological symptoms when you do your history. So dysmenorrhea in general is really, really common. Up to 90% of women will have dysmenorrhea, but many of them don't ever seek any medical help for it. They just think it's normal. And it obviously can have an impact on quality of life, so the missing school and work, low mood, etc. So that's why it's important to learn about. Obviously, we're not going to go through primary dysmenorrhea because it's essentially just caused by prostaglandins, has no real underlying pathology. So to go through secondary dysmenorrhea, these are the main causes. So endometriosis and adenomyosis. So endometriosis is endometrial tissue outside of the endometrium. So you can see here on the outside of the uterus, in the ovary. It can be in the abdomen, on the bladder, attached to the bowel, that kind of thing. Adenomyosis refers to the same thing, but it's basically those little bits of endometrial tissue, instead of being outside of the uterus, that actually form inside the myometrium, and that can cause pain. So these ladies with endometriosis, adenomyosis usually present with cyclical or chronic pelvic pain. Usually gets worse just before menstruation, and they also usually have menorrhagia. They might have other symptoms like rectal pain, rectal bleeding, deep dyspareunia, things like that. So all of those are kind of abnormal symptoms and should be investigated further, shouldn't be said that this is just primary dysmenorrhea. So fibroids are really, really common. We'll talk about them a little bit more later for menorrhagia, but basically they usually present with lower abdominal pain and then menorrhagia, and you might find a pelvic mass when you do your examination. PID is obviously pelvic inflammatory disease, so an infection inside the uterus or inside the pelvis itself. They usually have this abdominal pain, which might be worse during their period, but is usually chronic as well. They might have abnormal vaginal bleeding, so intermenstrual or postcoital, and they might have abnormal discharge, or they might be systemically unwell, so things like having a fever. Ovarian cancer can cause dysmenorrhea, so again, it's more likely to be more chronic pelvic pain, which is worse around menstruation. They might get bloating or abdominal distension, and they might get urinary urgency and frequency, and they might have abnormal bleeding, so they might intermenstrual bleeding or postmenopausal bleeding if they've gone past the menopause. Cervical cancer, same. They're likely to have deep dyspareunia and intermenstrual or postcoital bleeding, or postmenopausal bleeding, again, if they're past the menopause. And also iatrogenic, so after you've put in an IUD or an IUS, they might get more dysmenorrhea, menorrhagia, bleeding or spotting, and you might have to take the IUD or IUS out to actually sort their symptoms out. So those are the main causes of secondary dysmenorrhea. Again, going through the investigation, so history and exam is super important. Just remember your Socrates, so we're talking about pain, go through your Socrates, the associated gynecological symptoms, so always ask about things like PV bleeding, PV discharge, abnormal intermenstrual postcoital bleeding, and then non-gynecological things like change in bowel habit, change in lower urinary tract symptoms, etc. And then examination, you want to do an abdominal exam, so fibroids, if they're big, you can often feel. If there's like a cancerous mass, you might be able to feel that. And a pelvic exam, so a speculum and a pelvic exam. Obviously, if they're very young, then not. But otherwise, you're having a look at the cervix, and you can do your bimanual to palpate for any masses in the adnexa. And then your primary investigations, again, pregnancy test to everyone. A transvaginal ultrasound, so things you can see on that are things like fibroids, cancers. You can also see endometriosis and adenomyosis, and if they've had a IUD put in, you can assess the position and just make sure it's in the right position and it's not causing them pain because it's come out or it's come into the wrong position. Swabs, so there you're looking for infections for PID. A smear test for cervical cancer or cervical changes of the cervix. Hysteroscopy or colposcopy, again, if you're thinking they have cervical cancer or if you're thinking they have fibroids that might be causing this. And yeah, referral. So most of them are going to be referred. If you think there's a red flag and you think they've got a cancer, obviously referral on the 2-week break to see a gynaecologist. And so someone said, what does iatrogenic mean? Iatrogenic means caused by us, caused by doctors. So us giving them medication, contraception, things like that. So it's not actually a pathology that's going on with them. It's us that have caused that sign or symptom. And then just to talk about the management. So this primary management is for essentially primary dysmenorrhea, and also these things are obviously helpful in secondary dysmenorrhea, but secondary dysmenorrhea needs more investigation. But things like applying heat, TENS machines, NSAIDs and paracetamol, etc. And then contraception. So obviously if she doesn't want to get pregnant, things like the combined oral contraceptive pill or progesterone only contraception have been shown to decrease dysmenorrhea. Secondary is all there. It's going to depend on what you think the underlying cause is. Obviously a cervical cancer, they might need it resected, or they might need a hysterectomy. Same with ovarian cancer, that's probably going to need to be removed. They might need chemotherapy, radiotherapy. PID is usually managed with antibiotics, depending on what the cause is, chlamydia, gonorrhea, etc. Fibroids, these can be resected via the cervix, so kind of like a hysteroscopy, and then if the fibroid is into the uterine cavity, you can just remove it through the vagina. They might need a myomectomy, so if the fibroid's not sitting in the uterine cavity, if it's sitting in the myometrium, you can remove it, but that's a laparoscopic or an open operation. You can embolize the uterine arteries to stop the blood supply to the fibroid and hopefully shrink it. Or some women, if they are done with their family, they might request a hysterectomy. That's usually more to do with menorrhagia. That's why they request that. And then endometriosis and adenomyosis, usually you suggest the Mirena coil. It's been shown to help with their pain. Obviously, again, that's if they don't want to get pregnant. But if they're having severe pain, they usually get a diagnostic laparoscopy, have a look inside, and then you can sort of burn away or excise the deposits of endometriosis, and this can help with their pain, but actually a lot of the time it doesn't help with their pain, unfortunately. So that's kind of dysmenorrhea. Again, we've got another quick poll for you. So I'll just start that one up now. So pain in primary dysmenorrhea is thought to be caused by what? Okay, fab, I think everyone's voted. So yeah, perfect, I clearly made that one clear. Prostaglandins, that's the answer. So that's primary dysmenorrhea. So just to move on to menorrhagia, and this is the last topic, I'll try and speed up a little bit. So menorrhagia is excessive or heavy menstrual bleeding that occurs regularly, so essentially that occurs with the period rather than just bleeding all the time. And the way it's defined is interference with the physical, emotional, social or material quality of life. So NICE tries to quantify how much this should be, and as we said earlier, it's usually considered to be more than 80 millilitres in one period, or a period lasting for more than 7 days. But realistically, it's really difficult to measure blood loss, and we often ask women how often are you changing your pad or tampon? Do you have large clots? Are you flooding through your sanitary products? Those are the kind of things that are more likely to be asked women to assess whether it's heavy or not. But realistically, if a woman says it's affecting her quality of life, no matter how heavy it is, that's considered to be menorrhagia. It's one of the most common reasons for referral to a gynaecologist, and the peak age of incidence is between 30 and 49. And 5% of women in that age group speak to their GP each year with menorrhagia, and up to 20% of women in the UK will have a hysterectomy before the age of 60 to relieve menorrhagia symptoms. So going through the causes, there's quite a few causes, so we'll go through them a little bit quickly. So the first one is fibroids, probably one of the most common causes. So this is a picture of fibroids, and it's kind of like what I was saying before. So if the fibroid comes into the cavity like this one, or it's a submucosal fibroid, so right near the endometrium like this one. These are the two that are most likely to cause menorrhagia, because obviously they're sitting near the endometrium and they increase the surface area of the endometrium, so they're more likely to cause menorrhagia. These other ones can cause pelvic pain, and they can also cause like pressure symptoms, so problems with urination and things like that. So 10% of women with menorrhagia will have fibroids as the cause. Endometriosis and adenomyosis, like we talked about, these can cause menorrhagia as well as dysmenorrhea, pelvic pain and infertility. PID or infection, as we talked about before. Polyps, hyperplasia and malignancy, so these can all cause menorrhagia. They're more associated with postmenopausal bleeding, but they can happen in women before they've reached the menopause. So other symptoms are things like postcoital bleeding or intermenstrual bleeding and pelvic pain. Again, a cervical malignancy or PCOS can actually cause menorrhagia as well, but it's usually associated with oligomenorrhea. So they have irregular bleeding, but the bleeding's very heavy when it does come. Other things are obviously things like things that can affect your clotting, so von Willebrand's or whatever. If the patient's known to have that, that might cause menorrhagia. Hypothyroidism can cause menorrhagia. And then again, our iatrogenic causes, so women who are anticoagulated, and also lots of contraception can cause irregular or heavy bleeding. The main culprit for menorrhagia is actually the copper coil. A lot of women complain of heavy bleeding with that. And then for a lot of women, we don't find out what the cause of their menorrhagia is. It's called dysfunctional uterine bleeding. If there's no cause identified, and this is actually 40 to 60% of women who present with menorrhagia, so it's actually a massive amount of women we never find a cause. Again, just to go through the investigation, so history and examination really important. You want to take a full history, including a menstrual history. Your associated gynecological symptoms are things like intermenstrual crystal bleeding, pain, pressure symptoms, change in vaginal discharge. If you're thinking more of a systemic thing, you might ask about if they bleed from any other areas, mucous membranes, etc., bruising, things like that. You want to ask them about their menstrual history, their obstetric history, whether they're wanting to have children, because that might affect your management, their smears, and the sexual history if thinking about PID, or you also ask about contraceptives, and then finish the rest of your history, so past medical history, etc., etc. So ideally all women would then have an abdominal exam, speculum and a bimanual to look for anything obviously abnormal, and if you think it's a systemic problem, then you would do a systemic exam, for example a thyroid exam if you thought it was hypothyroid. And then your tests, so all women presenting with menorrhagia should have an FBC. Nearly 2/3 of women will have iron deficiency anemia, so it's really important that even if there's no cause for their menorrhagia, they get an FBC so you can manage their anemia. If you can't find any underlying cause and you really think this might be due to nothing, then sometimes they won't be referred for any further tests. But I think most of the time they will at least get one of these tests depending on what the likely cause is. So a smear if it's thought to be cervical, you know, this for PID, TVS can look at endometriosis, adenomyosis, fibroids, MRI pelvis can also be done if the woman doesn't want a TVUS, colposcopy and hysteroscopy if you think there's a malignancy there. And these systemic blood tests, basically, if you think it's not actually a gynecological problem. I just think there's a couple of questions, sorry. Oh, thanks. What's a bimanual? So a bimanual is an examination essentially where you insert 2 fingers into the patient's vagina. You're feeling for the cervix, and then you use your other hand and you basically do an abdominal examination at the same time. And the reason for doing that is, one, if you move the cervix and if you feel a mass in the abdomen, and with your other hand you move the cervix and the mass moves, you basically know this is a gynecological associated mass, usually a fibroid or a uterine malignancy that's moving. And you also can then feel either both the adnexus, so both the iliac fossa essentially, and that can allow you to feel for any masses there, so any ovarian masses or something you might be able to feel on that examination. It's obviously an intimate examination, but it can be really, really helpful to give you further information of what might be the cause. Fine, and then just going on to management. This is a really busy slide, so sorry about that. And you can have a look at it in more detail afterwards. But primary care management can be done if either you don't think there's an underlying pathology or they've been investigated and nothing's been found. You might see a lot of women come in and they're on tranexamic acid or mefenamic acid, and they basically aiming to clot the blood and reduce the amount of bleeding. Otherwise, first line is actually the Mirena coil, and that can be given to anyone with no pathology, very small fibroids or endometriosis, adenomyosis, that can help them. And then these are other forms of hormonal contraception or cyclical oral progestogens, things like northisterone you might have heard of. These can actually reduce the amount of bleeding, and women will still have periods and still have a withdrawal bleed, but it can very much reduce the amount of bleeding that they have. And then treating the cause. So if it's something simple to treat, then treat the cause, and the amenorrhoea should hopefully resolve. You need to think about referral. If they have red flag symptoms, then obviously you want to refer on a 2-week wait. If they have other things, like you think they have fibroids, but they're causing a lot of pain or pressure symptoms, then you would refer as urgent or routine to a gynaecologist. And obviously, if it's something else, like a hypothyroidism or whatever, then you might refer to endocrine, or you might just manage it in GP. And these are the things, essentially, the way that we manage depending on the cause. And we kind of talked about these before. So fibroids, it's essentially about resecting them. Polyps, you can do a hysteroscopy and remove them. A cancer, it depends, but you're essentially going to have some form of surgery and then potentially chemotherapy and radiation. Endometriosis and adenomyosis, Mirena is the first line, but like we said before, they can have a laparoscopy and they can have ablation or excision. And if you find no cause whatsoever, but all these treatments that we've talked about at the beginning haven't worked, and the woman's still bleeding very heavily, you can refer to gynaecology, and they can still do some of these things. So they can do ablation of the endometrium. So that involves basically burning away or lasering away the endometrial lining to try and reduce the bleeding. This will actually reduce their fertility, so they need to be warned about that. Uterine artery embolization can be used for fibroids, but it can also be used for when no cause is found, hopefully to reduce the period. Obviously, a hysterectomy can be done if the woman doesn't wish for further pregnancy. And these GnRH analogues, they basically induce a menopause. So we don't use them that much, and a lot of women don't like them because although the bleeding reduces, they also get all the other symptoms of menopause, which most women don't want, especially if they're young. So that's basically the overall discussion about menorrhagia, which is probably one of the most common things you'll see in gynaecology and could come up in an OSCE exam. So I think now we've just got one last question and then some cases to go through, and then that will be the end of the lecture. Sorry, that's gone on a little bit. So let me just put the poll up for this question. So what type of fibroids are most likely to cause menorrhagia? I think basically everyone's voted. So yeah, 60% of you said submucosal and intracavity. That is the correct answer. If I just quickly go back to the side of the picture. So this intracavity fibroid and this one that sits just below the endometrium, those are the ones that are going to cause increased bleeding because they increase the surface area of the endometrium. These ones which are on the outside of the uterus, inside the muscle, or like inside the pelvis, they're less likely to cause menorrhagia because they don't actually affect the endometrium itself. But then just a couple of cases. So I'll give you, I'll open the poll and then I'll just give you a few minutes to read the case and answer the question. Fab. So I think most people have voted, and 94% of you said pregnancy test, which is fab because that is the correct answer. So me going on about it has worked. So yeah, she started a sexual relationship. She's 16 years old. She could easily be pregnant. So pregnancy test is always the first thing you should do. And this is something you can do really easily in GP as well. Okay, so second case again, I'll give you a couple of minutes to read the case. Fab, so I think that's everybody. So perfect. Most of you said PCOS. So yeah, the answer is PCOS. She had previous irregular periods and now she's got no periods at all. Normal FSH and LH, which is great, and the testosterone is mildly raised, so that suggests PCOS is the most likely diagnosis in this case. And finally, the last question. Again, I'll give you a second to read the case. Fab, I think that's most of you. So yeah, so 70% of you said Sheehan syndrome, and that is the correct answer. To be honest, this is one of these weird questions, these weird syndromes that come up in like multiple choice answers and stuff that actually don't happen that often in real life. But yeah, Sheehan syndrome is the one that occurs usually after a PPH. So the pituitary gets bigger during pregnancy, and then she has a big PPH, and it causes a pituitary infarct. It will cause low levels of all hormones, so she won't get her period, but she might also be unable to breastfeed and might also have symptoms of other things like hypothyroid, etc. It usually doesn't develop straight away and is quite slow, but it can be sort of very sudden and significant straight after birth. Some of the rest of you voted for Asherman syndrome. So Asherman syndrome is the one where you have basically scar tissue inside the uterus from a previous surgery, and that's what Asherman's is. So not in this case, but obviously it is a cause. So that's kind of the summary. I'm just going to leave the feedback side up for a minute, and I'd really appreciate if while I answer the questions and just go through the summary, if you could click on the link or the scan and just give some feedback, it would be fab. So today we've basically talked about amenorrhea, so that's absence or cessation of menstruation, divided into primary and secondary, depending on whether menses has happened before or not. Oligomenorrhea is infrequent periods, irregular bleeding less than every 35 days. Dysmenorrhea is painful cramping around the time of menstruation. Menorrhagia is excessive menstrual loss, interfering with patient's quality of life. So, like I said, all of these slides will be on Becoming a Doctor website, and the notes sections have got some much detailed notes in them to help you with the revision, hopefully. I'm just going, I think there's 2 questions. So is the progesterone challenge used more to investigate amenorrhea? I'm not entirely sure what you mean by the progesterone challenge. Sorry, I'm not entirely sure what you mean by that one. If you want to type, I can try and answer it if you want to say what you mean by progesterone challenge. And the second one, what is the mechanism for the need for osteoporosis prophylaxis? So essentially we know that estrogen is protective against osteoporosis. So women are at lower risk of getting osteoporosis than men until they reach their menopause, and then they become just as at risk because their levels of estrogen are very low. So if women are having problems with periods, and that's due to a lack of estrogen, for example, Turner's, where they have streaked ovaries and they're not producing estrogen, then they're going to be at that higher risk of osteoporosis throughout the whole of their life, rather than just after menopause. And so you need to think about prophylaxis of this. And like I said, it's usually done with things that contain estrogen, so HRT or the combined oral contraceptive pill. So I hope that answers that one. So I think that's it. Thank you very much for listening. And if you've got any more questions,